That one's crazy. If you haven't seen it, this is one of those that has just a very characteristic appearance, and forevermore you will know this one. I will tell you, oftentimes I show this to residents, and their first guess is bilateral subcapsular hematomas. It's possible, but it's so homogeneous and so extensive and so bilateral that is extremely unlikely, right? That you would have a bilateral subcapsular hemorrhage like that. Even in the face of massive anticoagulation, I can't see any reason that you would develop this in your kidneys bilaterally and nowhere else. So that one is not bilateral subcapsular hematomas. This is what's known as nephroblastomatosis. It's common in infants. It only happens in infants. And it's a pre-malignant condition. So it's not actually a malignancy, but it can ultimately develop into a renal malignancy. And so they often treat this with just a light dose of chemotherapy. So there it is, those hypodense subcapsular masses kind of distorting the underlying renal parenchyma. Just a really typical appearance for this. Nephroblastomatosis. This is abuse, right? This is abusive trauma. Multiple rib fractures in different stages of healing, right? You've got some that look fairly acute, like this one, and you've got some that look older, like this one, with hypertrophy and sclerosis, callus formation out adjacent to some of these ribs. So they're probably hyperacute, subacute, and older rib fractures here. So, and note this location. This is the posterior rib fracture that people are always talking about in abusive injuries, right? It happens right there because rib fractures from abusive trauma are due to squeezing. And when the rib cage is squeezed, basically the rib is pinioned against the transverse process. See that location? Right there. Right, and so it's something to do with the mechanics here where the rib abuts the transverse process that it has a tendency to fracture right there. Anterolateral is the other place that you'll see these in squeezing injuries. So multiple fractures of the ribs, different phases of healing. That's abuse, and there's really nothing else it can be. So definitely a bowel obstruction, right? Look at all those dilated loops. And this is clearly in an infant as well. So when you see that, you're thinking, I think, three big things, right? It could be an intussusception. It could be a malrotation. And I think the other big thing to think of is a hernia, right? So you guys have probably heard my story that when I was an ER doctor, I had this guy, he had dilated loops on his abdominal film. He had a big distended abdomen. And I called the big medical center to transfer the guy. And I said, I've got a small bowel obstruction. And the guy on the receiving end said, does he have a hernia? And I was forced to say, I don't know, because that should be right where you go, right? Is down to the scrotum in any male, especially with a small bowel obstruction, it's right there, and you can find the causative hernia very easily. So in radiology, it's no more accessible than any other part of the body, but definitely remember to look down there. I've got a coronal on this, which is great because you can see it coming through the inguinal ring right there. Right, and that herniated bowel is getting a little thick-walled as well. And that's a big point with our ER referrings. They always want to know, is there evidence of strangulation? Such that I recommend to all our radiologists that if you see a hernia, the next thing they're going to want to read in your report is whether or not there's evidence of strangulation. So we're talking about stranding around the herniated bowel loop, thickening of the wall, and maybe even perforation with extraluminal gas. But that comment, I think, is worth making anytime you're reporting a hernia, is saying no evidence of strangulation, evidence of strangulation. Right. And we had an internal hernia recently, a closed loop hernia, closed loop, obstruction that had a bunch of mesenteric stranding. And the radiologist called it perfectly, but didn't cite the possibility of vascular compromise or strangulation. And it ended up becoming a medical malpractice case, even though everything else was reported accurately. Another one with bowel obstruction, right? That small bowel is way too dilated. That's an intussusception. You got a nice target appearance here, mesenteric fat and vessels being dragged into the lumen. Right there on the axials, there's the small bowel dilation. So there it is there. Vessels and mesenteric fat are your indicators that we've got a bowel loop intussusception. So there it is here, and actually there's another shot on the coronal that's really nice right there. And of course, remember these go in the direction of peristalsis, and you have an intussusceptum, which is what is intussuscepted, into the intussusceptiens, which is the receiving portion of bowel. And also note, you got two S's at the beginning and one S later. I struggle with spelling intussusception almost as much as spelling Toulouse for the Toulouse fracture.
For starters,
I screw those up all the time. So most common location is usually ileocecal, but certainly these can happen. You can have colocolonic and enteroenteric as well.
But so you got.
All right. And remember, too, I'm sure most of you know, with children, there doesn't necessarily have to be a lead point. In fact, oftentimes they cite like mesenteric adenitis as enough to cause this. When you see these in adults, you've got to have a much heightened vigilance with regard to a potential underlying neoplasm. And in adults, obviously, if it's a lipoma, which is a very common lead point lesion, it'll be really apparent because of the fat. But in others, I've seen plenty of colon carcinomas present with intussusceptions, and it can be pretty subtle, right? Pretty difficult to separate, say, some wall thickening associated with the intussusception from an underlying colon cancer. So look very carefully, especially in adults. It doesn't bother me much to not find a lead point in a child like that one, but in an adult, I would be racking my brain and saying, what am I missing here? So as a hint, you can see this one actually goes up into the cervical region, and that's actually the most common location to see this lesion. They usually start in the neck and progress down into the thorax or just involve the neck. So this one is a little unusual in that the bulk of it is extrathoracic instead of cervical, but it's still clearly got a cervical component. So it's mostly cystic with a few soft tissue elements, and it's entirely extrathoracic slash paraspinous cervical. That is a cystic hygroma, and you're speaking my old guy language because now they call it a congenital lymphatic malformation. But I was raised on cystic hygroma. There's one more look at that one. The sagittal is really helpful here. Right there, we're watching right now. There it went. This is involving the anterior abdominal wall and the dome of the bladder. Right, with posterior urethral valves, we'd be looking at big time hydronephrosis, right? And dilation of the prostatic urethra, at least the proximal portion.
Oh yeah, so like a urethral cyst, yeah.
Yeah, so that is, you see where it's originating is right anteriorly here. Right there. So that is a persistent urachus. Right? You get a tract from your umbilicus down to the dome of the bladder, and it can even leak urine in some unusual cases. But its real problem is that there's a tendency to superinfection. And that actually is the beauty of this case, because a persistent urachus is very thin-walled. And so normally you'll just see a fluid tract down to the bladder dome. But in this case, you can see there's a shaggy thickening to the wall, which in the case of a urachus suggests that it's superinfected. The other thing I think is cool here is that you do get a metaplasia of the bladder dome. So look at the thickening of the bladder dome wall right here and that little tract going through it. They do get metaplasia here, and it actually does carry a risk of an adenomatoid type tumor that's very rare and not seen in most other situations. So there is some neoplastic risk on this one. Okay, well, I'll start you off on this one with multiple intussusceptions. Right, there are probably at least 3 intussusceptions here. The most prominent ones are right abdomen, which you'll see right here, right there, went past, right there. All right, there's the stalk. You've got mesenteric fat and probably a vascular pedicle there and a soft tissue mass right there. And then there's the big one right there. Look at that fatty vascular stalk sticking into the bowel lumen, and look at all those polypoid masses there. No, there's your lead point, right? There can be no question. There is an underlying process here. There's one intussusception, there's another, and then there's the big one right there. The polyps with this condition, Peutz-Jeghers, usually are small bowel. There can be colonic polyps. So if you see an isolated 1 or 2, as you see in there, don't let that dissuade you. But the bulk of them will be small bowel. And this is the one that presents with lip pigmentation as well.